Hello, this is Dr. Oviedo. Today we are going to discuss non-neoplastic lung pathology. Let's start with acute respiratory distress. Diffuse alveolar damage is the pathologic correlate of the clinical syndrome acute respiratory distress syndrome. ARDS is heavily covered in other parts of the cardiopulmonary course. We're going to focus on the pathology. Diffuse alveolar damage means there is damage to the pulmonary capillary endothelium and alveolar epithelium, which causes edema to enter the alveoli. This edema will result in hypoxia when the oxygen cannot cross the edema into the alveolar capillaries. This type of lung damage is a final common pathway which is secondary to many different clinical conditions. It is common in patients with shock. Other causes include aspiration, pancreatitis, smoke, or toxic gas inhalation. In the acute phase, there is alveolar edema. In the later phases, you get progression to hyaline membranes and thickened alveolar walls. It can also resolve to normal lung function. Let's take a look at the pathology. This is a normal lung, which of course has air in the alveoli. Here on the right, I have acute respiratory distress syndrome with fluid in the alveoli. In a later stage, you will get the hyaline membranes, which you can see as that thick pink material, and the alveolar walls will also become quite thick. Let's go on to obstructive lung disease. Emphysema is irreversible enlargement of the air spaces distal to the terminal bronchiole, accompanied by destruction of their walls. The clinical presentation includes dyspnea, weight loss, and impaired expiratory airflow on spirometry. The prognosis is variable. There are four main types of emphysema. Centroacinar emphysema obviously refers to the condition when central or proximal parts of the acini are affected. The distal alveoli are spared. In this type, the upper lobes or apical segments are more severe. This is common in heavy smokers. Panacinar emphysema refers to the condition when the acini are uniformly enlarged from the respiratory bronchiole to the terminal alveoli. This generally affects the lower zones and bases of the lung more severely. This is the type of pathology you will see in alpha-1 antitrypsin deficiency. Distal acinar emphysema, of course, means the distal acini are more involved. This generally involves the upper half of the lungs and can occasionally present as a spontaneous pneumothorax in young adults. Irregular emphysema is generally due to scarring and is usually clinically insignificant. The pathogenesis is that inflammatory mediators and leukocytes are increased in the affected parts. There is a protease-antiprotease imbalance with a relative deficiency of protective antiproteases. You can also have oxidative stress. Tobacco smoke, alveolar damage, and inflammatory cells all produce oxidants. Infections such as bacterial or viral infections don't initiate tissue destruction, but they may exacerbate the associated inflammation and bronchitis. The tissue damage causes loss of elastic recoil in the small airways and then collapse of the respiratory bronchioles during expiration, despite the absence of mechanical obstruction. This diagram from Robbins demonstrates the numerous pathways that lead to alveolar wall destruction. I want to discuss emphysema pathogenesis and alpha-1 antitrypsin deficiency in detail. Alpha-1 antitrypsin belongs to the serpin family of protease inhibitors. Alpha-1 antitrypsin has autosomal codominant inheritance. Both alleles are expressed and both contribute to the phenotypic expression. Mutant alpha-1 antitrypsin is trapped in the endoplasmic reticulum of hepatocytes, which leads to decreased alpha-1 antitrypsin secreted into the plasma. Alpha-1 antitrypsin inhibits proteases, including elastase, which is secreted by neutrophils during inflammation in the lungs. Proteases, including elastase, then have increased activity in the lungs. Over time, this will lead to parenchymal lung destruction. Let's take a look at the pathology. Here is our CT scan. This CT scan has a lot of dark areas, which means there has been parenchymal loss. You can see the remaining internal septa here, here, and here. There is a portion of normal lung medially for comparison. This CT scan would correlate with a lung that looks like this on gross pathology. There is loss of alveoli with remaining pulmonary septa. Here I've put arrows on the septa, here and here. Down here, this is what the histology would look like. You have loss of alveolar walls. There is too much space in this image. Let's go on to asthma. Asthma is a chronic disorder of airways caused by reversible bronchoconstriction caused by airway hyperresponsiveness to a variety of stimuli. The clinical presentation is recurrent episodes of wheezing, shortness of breath, and coughing. Triggers include viral infection, smoke, cold air, stress, and exercise. This is caused by an interaction of genetic susceptibility with the environment. Detailed pathogenesis of asthma is covered elsewhere in this course. The pathology includes eosinophils, thickened basement membrane, increased submucosal glands, increased airway goblet cells, mucus plugging, and hypertrophy of the bronchial wall smooth muscle. Let's take a look at the pathology. Here is our slide that shows markedly increased submucosal glands in the bronchus. For orientation, here is the cartilage, and here is the bronchus lining. These purple shaded regions correspond to the increased amount of submucosal glands. Here I have a normal bronchus for comparison. Here I've shaded the submucosal glands in purple also. You can see there are not very many submucosal glands in the normal bronchus. Here again is our same picture. Here is a higher power of the bronchus lining. You can see there is a thickened basement membrane and very thick, smooth muscle. Here on the right, I've shown the eosinophils. This is a picture of a bronchiole. You can see there is a mucus plug. Here on the right, I've shown the increased goblet cells, the thickened basement membrane, the hypertrophy of the smooth muscle, and the increased eosinophils. I want to discuss a few other things that you might hear about when you're studying asthma. This is a Kirschmann spiral. This corresponds to the mucus plugs that we were seeing in the bronchiole. You can imagine that in life, the mucus plug would have a long shape. When it gets coughed up, it will retain its long shape in a sputum sample. You can see it right here. Sputum is material which is coughed up from the respiratory tract and does not refer to saliva. The Kirschmann spiral is, of course, composed of the extruded mucus plug. Another thing you will occasionally hear about are Charcot-Leyden crystals. Charcot-Leyden crystals are composed of an eosinophil protein called galectin-10. Let's go on to bronchiectasis. Bronchiectasis is a permanent dilation of bronchi and bronchioles due to destruction of smooth muscle and elastic tissue by chronic necrotizing infections. There are numerous conditions that can lead to bronchiectasis. The clinical presentation is generally a cough. There are many different underlying conditions. Common conditions include cystic fibrosis, which is due to autosomal recessive CFTR mutation, primary ciliary dyskinesia, which is autosomal recessive due to ciliary motor protein mutation, Carter-Jenner syndrome, which includes cetus inversus, bronchiectasis, sinusitis, and male infertility. The third common condition is allergic bronchopulmonary aspergillosis. I want to discuss the pathology of cystic fibrosis. Here is an explanted lung which was removed for lung transplantation from a cystic fibrosis patient. Here are the bronchiectatic airways filled with purulent material. Here on the right, I have a photograph demonstrating the purulent material in the lumen. There is also significant submucosal chronic inflammation. Let's go on to restrictive lung disease. Let's discuss idiopathic pulmonary fibrosis. This is a clinical pathologic syndrome marked by progressive interstitial pulmonary fibrosis and respiratory failure. The fibrosis arises in genetically susceptible patients prone to aberrant repair of recurrent alveolar epithelial cell injury caused by environmental exposures. Environmental factors include smoking, metal fumes, wood dust, farming, hairdressing, and stone polishing. There are also sporadic forms. Genetic susceptibility variants include MUC5B variant, which is the most common genetic susceptibility variant, telomerase mutations in TERT and TERK, which are components of telomerase. These are generally germline loss of function mutations. You can also have surfactant component mutations. Endoplasmic reticulum stress due to folding defects in alveolar type 2 pneumocytes leads to pulmonary fibrosis. The clinical presentation is generally over the age of 50 and includes dyspnea, tachypnea, end inspiratory crackles, and cyanosis. The prognosis is poor. Medical treatments are available, but generally lung transplantation is the only definitive therapy. Let's discuss the pathogenesis in more detail. Here I have a drawing from Robbins which shows the pathogenesis we've been discussing. Here on the right is a picture of a normal alveolus for comparison to the later pictures. Here we have moderate pulmonary fibrosis in which you can see the alveolar walls are thickened compared to the normal picture above. Down here I have severe pulmonary fibrosis where the alveolar walls are so thick that it is difficult to recognize this as lung. Here I have a gross picture of a lung with pulmonary fibrosis. Here on the right there is marked fibrosis. There is also relatively normal lung here for comparison. Another thing I want to remind you is that these lungs will feel very firm in the area of fibrosis. This is something which of course you can't really see in the images. Let's go on to bronchiolitis obliterans organizing pneumonia. This is a clinical pathologic syndrome of unknown etiology. The clinical presentation is cough and dyspnea in the mid-50s. Radiology will show patchy subpleural or peribronchial areas of airspace consolidation. The therapy is oral steroids. The prognosis is very good with therapy. Let's take a look at the pathology. Here is our photograph. You can see there are balls of fibroblasts with loose connective tissue in the alveolar ducts, alveoli, and bronchioles. Let's go on to sarcoidosis. This is a systemic granulomatous disease of unknown cause that may involve many different tissues and organs. It's likely a disorder of immune regulation in a genetically predisposed individual. Sarcoidosis has non-caseating granulomas. Immunologic abnormalities include high levels of CD4 T cells in the lungs that secrete T helper 1 dependent cytokines such as interferon gamma and IL-2 locally. The most common clinical pattern is bilateral hilar lymphadenopathy or lung involvement. In order to diagnose sarcoidosis, you must exclude infectious causes of disease such as mycobacterial and fungal infection with microbiology studies such as PCR. You must also exclude exposures that can cause granulomatous disease such as borreliosis due to mining or manufacturing. The clinical presentation of sarcoidosis is generally adults 20 to 40 years old, but this can affect any age group. There is a higher prevalence in women, and sarcoidosis rates are 10 times higher in the African American population. There is an HLA-A1 and HLA-B8 association. Clinical manifestations include shortness of breath, cough, chest pain, and hemoptysis. Constitutional symptoms include fever, fatigue, weight loss, and anorexia. You can have lymph node involvement, eye involvement, skin lesions, and involvement of other organs. On laboratory studies, patients will generally have polyclonal hypergammaglobulinemia, which is a manifestation of helper T cell dysregulation. Let's take a look at the pathology. Here I have a photograph demonstrating non-necrotizing granulomas distributed along the bronchovascular bundles. Here is the bronchiole, and here are numerous non-necrotizing granulomas. I want to discuss other things that you might read about as you study sarcoidosis. These are nonspecific findings, which means you can see this in other diseases. This is a Schaumann body, which is a laminated concretion composed of calcium and protein. This can be seen in sarcoidosis. And here is an asteroid body, which can also be seen in sarcoidosis. The composition is unknown. Sarcoidosis has an unpredictable course. It may be progressive or may have periods of activity interspersed with remissions, sometimes permanent, that may be spontaneous or induced by steroid therapy. 65 to 70% of patients will recover with minimal or residual manifestations. 20% of patients will have permanent loss of some lung function or some permanent visual impairment. 10 to 15% of patients may die of cardiac or central nervous system damage, but most will succumb to progressive pulmonary fibrosis and cor pulmonale. Okay, I hope you've enjoyed reviewing non-neoplastic lung pathology.